Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're continuing with our ongoing series entitled The QME Physical Exam, and in this section of the program, we're discussing how to obtain accurate and objective range of motion measurements as described in the AMA Guides chapters 15, 16, and 17. And in our last session, we went into great detail as to how to obtain accurate and objective range of motion measurements for the lumbar spine. Now, any discussion of lumbar spine range of motion testing must also include a discussion of what the AMA Guides refer to as the accessory validity test. Now, the accessory validity test, as described on page 406, in chapter 15 of the AMA Guides, is used to assess the examinee's sincerity of effort on physical examination maneuvers. And the AMA Guides use the narrow and specific window, the looking glass window, into which we can peer in order to get an idea as to the examinee's sincere participation in the physical examination. The window through which we make this assessment is lumbar flexion and extension testing. So we use lumbar flexion and extension testing as an overall indicator as to the examinee's sincerity of effort, and in order to make that assessment, we employ the accessory validity test. And in today's video, I'm going to share with you exactly how to obtain those measurements on a live examinee. And we'll use those measurements to make our own determination on this particular examinee as to the sincerity of effort and the validity of lumbar flexion and extension measurements as it relates to the examinee's overall lumbar range of motion testing. And before we get into that actual discussion, I just want to make a few comments regarding lumbar range of motion testing and range of motion testing in general. And I want to preface that discussion by letting you know that I've had the opportunity, and I have the ongoing opportunity, to review many qualified medical evaluators' reports. And in my review of hundreds and hundreds and hundreds of qualified medical evaluators' reports, I conclude that the majority, and I'm going to put this, I'm going to estimate this as approximately greater than 80%. The majority of qualified medical evaluators do not perform their range of motion testing in general and their range of motion testing specifically of the spine in accordance with the principles that are described in the AMA Guides. And in today's discussion, we're talking about chapter 15 of the AMA Guides. Now, I found that many qualified medical evaluators perform their spinal range of motion testing by eyeball, by eyeball, or what is commonly referred to in the trade as by visualization. But I think we can agree that the term eyeballing range of motion is an accurate euphemism for what is referred to as visualization. Qualified medical evaluators no more than eyeball range of motion testing, and they extrapolate their findings on range of motion testing by comparing their findings to published normal range of motion testing. So, for example, if a qualified medical evaluator determines that full range of motion testing on lumbar flexion is 90 degrees, and I'm just making this up as a number, and the examinee comes up short of 90 degrees, or short of touching their toes with their fingertips, the qualified medical evaluator extrapolates that range of motion to be perhaps 70 degrees, or some degree measurement short of what is the published normal for that particular range of motion. So qualified medical evaluators are simply eyeballing the range of motion measurements. Or a more advanced qualified medical evaluator will perhaps use some other type of measuring instrument, perhaps a goniometer, or perhaps a tape measure to measure distance of fingertips to floor. And qualified medical evaluators are using all manner of describing their range of motion methods except for the manner described in the AMA guides. And in my opinion, this is absolutely unacceptable. In my opinion, if you're going to be a qualified medical evaluator, if you're going to be using the AMA guides, if you're going to be quoting the AMA guides, if you're going to be providing for permanent impairment ratings out of the AMA guides, then your physical examination must exactly comport and comply, with the descriptions of the measurements and how they're obtained according to the AMA guides. Does that make sense? Or is this a crazy notion that I'm simply making up out of my head? Now, qualified medical evaluators tell me that they don't have the inclinometers that are described in the AMA guides. And I'm here to tell you that you must obtain inclinometers in performing your range of motion testing of the spine. So there are many different types of inclinometers available on the market. These are my inclinometers here. And this is a dual inclinometer system that is digital. And the beauty of having digital inclinometers, dual digital inclinometers, is that unlike non-dual, and unlike single inclinometers, with dual inclinometers that are connected, you don't have to perform any of the subtraction or mathematical formulas required in order to obtain the range of motion measurements. The machinery does it exactly for you. So with this type of inclinometer system, each movement at each one of the inclinometers creates a recording on the display of the master goniometer, the master inclinometer. And you don't have to do that yourself, which dramatically reduces the workload involved in obtaining range of motion measurements. So you must obtain inclinometers in order to do your spinal range of motion testing, and I recommend that you obtain dual inclinometers, dual digital inclinometers, if you want to simplify your work and you want to be involved with this type of work for many years to come. It only makes sense that you must make a minimal investment in your future as a qualified medical evaluator to obtain the necessary instruments described by the AMA guides. So that's one comment I want to make about examination instruments. The second one that I want to make is that I want you to know that when someone reads your report, they make an assessment of you as an evaluator through the window of your report. And your report tells the reader of the report many things about you. And one of the assessments that the reader of the report is making about you as a qualified medical evaluator is your attention to detail. Your attention to detail. Now, when the AMA guides describe range of motion testing as involving 3 separate and distinct measurements on each particular plane of range of motion testing, for example, with cervical flexion testing, we're required to obtain 3 measurements on cervical flexion testing, and then we then take the average of the 3 measurements. Well, when the reader of your report reviews your range of motion testing and learns that you obtained only 1 measurement, not 3 as described by the AMA guides, the reader of the report concludes that your attention to detail is lacking, is absent, okay? Similarly, in lumbar spine range of motion testing, when the reader of the report reads your range of motion measurements of the lumbar spine, do you think they compare your described normal range of motion values with the normal range of motion values described in the AMA guides? So let me ask you, if the AMA guides describe normal lumbar flexion as 70 degrees, And in your report, you state that the examinee has 40/60 lumbar flexion measurement, and you describe normal range of motion as 60, whereas the AMA guides describe normal range of motion as 80. What do you think the reader of your report thinks about your attention to detail and your fastidiousness and your meticulousness of preparation as a qualified medical evaluator? What do you think the reader of your report thinks to themselves? They're making their own validity assessment of you by reviewing your QME report. So that's the second comment that I wanted to make about range of motion testing and examination instruments. The third comment that I want to share with you is that when you fail to obtain spinal range of motion measurements through the use of inclinometers, as described in the AMA guides, you significantly and severely hamstring yourself as a qualified medical evaluator, because at least as regards to spinal impairment ratings, half of the entire universe of spinal impairment ratings revolves around range of motion measurements and accurate range of motion measurements. It's called the range of motion method. In other words, we have two main methods of rating spinal impairments. We have the DRE method and we have the range of motion method. Now, let's just imagine that you're a qualified medical evaluator that does not use inclinometers, that simply eyeballs range of motion measurements, and you provide for a permanent impairment rating for your examinee according to the DRE method. Now, imagine that you're in a deposition and one or the other of the attorneys says to you, "Doctor, I noticed that you provided an impairment rating using the DRE method. Is that correct?" Correct. "And is there a reason why you did not use the range of motion method?" And you explain your reasoning as to why you did not use the range of motion method, but of course you don't admit that the reason is because you don't have range of motion testing instruments, because they're approximately $500 or $600 and you never made that investment in your QME practice. You don't say that, but you provide some reason as to why you used the DRE method. And the attorney simply asks you, "Well, doctor, would you be so kind as to provide us a supplemental report wherein you provide us an impairment rating using also the range of motion measurement or the range of motion method?" What are you going to do? What are you going to say? How are you going to fabricate the numbers to come up with an impairment rating according to the range of motion method? Doctors, this is just 3 comments regarding why it's absolutely necessary that you obtain the range of motion testing equipment as described in the AMA guides if you want to be a credible player in the system, and if you want to be perceived as a meticulous, fastidious, and immaculate attention to detail qualified medical evaluator. Okay? So with that as our introduction, let's go on to discuss some of the key concepts regarding the lumbar spine validity assessment. Okay, so let's read from the AMA guides, and this is from page 406 in chapter 15. The AMA guides tell us that an accessory validity test can be performed for lumbosacral flexion and extension. And this also gives you a window to assess the examinee's overall credibility across the entire spectrum of your physical examination, not just lumbosacral flexion and extension. In this test, you begin by recording the straight leg raising angle of the supine examinee, and you compare the straight leg raising angle to the sum of the sacral flexion and extension angles. The sum of the sacral flexion and sacral extension angles. Now, how are you going to do this if you don't have inclinometers? I can always tell by reading a qualified medical evaluator's lumbar range of motion measurements, whether that be presented in a table format or some other type of bullet point format, I can always tell. And the reader of the report can tell. Okay, let me break this news to you. You think that the reader of the report cannot tell whether or not you have the proper test instruments. If you don't have the instruments and you're eyeballing your measurements, you're probably thinking that the reader of the report doesn't know, that they can't tell. Well, let me tell you. They can tell. And here's how they can tell. They can tell because in performing a complete lumbar spine range of motion evaluation, you must include the accessory test. And the accessory test requires sacral flexion and sacral extension measurements, which can only be obtained by inclinometers. Okay, so whereas you think you're clever in eyeballing and estimating range of motion measurements, you cannot eyeball or estimate sacral flexion and extension measurements. So a qualified medical evaluator who does not have inclinometers will not report on the accessory validity test because they don't have the necessary test equipment to do it, and they think that no one who's reading the report notices this omission. But let me tell you, no one misses this omission. You're fooling no one by failing to include the validity test, and it's absolutely necessary and required, and it demonstrates to the parties that you actually have the test instruments when you perform the accessory validity test, okay? And the reader of the report will read this in your report and will conclude that your attention to detail is enviable, is admirable, okay? Then we need to do a little bit of math. Then the guides tell us if the straight leg raising angle exceeds the sum of the sacral flexion and sacral extension angles by more than 15 degrees, the lumbosacral flexion test is invalid. Now, according to the AMA guides, and this is our Bible, and this is the principle that we apply in performing this accessory test, normally the straight leg raising angle is about the same, as the sum of the sacral flexion and extension angle. And the reason that they're about the same is because they measure the same movement. Both of these measurements measure motion at the hip joint, whereas one measurement is done with the examinee supine in an open kinetic chain, and the other movement is performed with the examinee standing in a closed kinetic chain. They both essentially measure the same movement, which is movement around the hip joint. So these motions should be roughly the same. So if the measurements fail to equate to each other by greater than 15 degrees, the AMA guides consider that to be an invalidity assessment, thereby disqualifying the examinee's measurements and findings, at least on lumbar flexion testing. In other words, this is indicative of insincere participation during the physical examination, specifically on lumbar flexion and extension testing. Now, also, if the individual resists passive straight leg raise testing without other evidence of radiculopathy, the accessory test is also invalid because there should be no reason as to why the examinee should resist or fail to participate fully in straight leg raise testing. Now, if you come up with an invalid assessment on this, the examiner should either repeat the flexion extension test or disallow impairment for lumbosacral spine flexion and extension due to lack of a sincere effort by the examinee. So let me ask you, have you ever provided for permanent impairment rating, probably using the DRE method if you don't have digital inclinometers? Have you ever provided for permanent impairment rating due to what you describe as decreased lumbar spine range of motion? Well, the guides tell us that unless the examinee can successfully pass the validity test Any permanent impairment rating due to loss of lumbar spine range of motion findings are invalid findings, and any impairment should therefore be disallowed. And here is the formula described by the AMA guides that you will use in performing your validity assessment. You take the tightest straight leg raise angle, comparing the left leg to the right leg, and you use the tightest leg, the leg that has the lowest average of 3 straight leg raise values, and you subtract from that the sum of the sacral flexion and sacral extension angles. And the sacral flexion and sacral extension angles are simply measurements that are recorded by placing your inclinometer here over the S1 spinous process, over the sacrum. So as the examinee goes through lumbar flexion, the inclinometer will move to record the amount of movement taking place at the hip joint. Now, if you use single inclinometers in recording your lumbar range of motion testing, when you have the examinee go through lumbar flexion, your top inclinometer will be placed at the T12 spinous process. The bottom inclinometer is placed at the S1 spinous process, and you take the T2 angle, the T12 angle, and subtract the S1 angle to subtract the amount of motion that's taking place at the hip. And through this mathematical formula, we obtain the true lumbar flexion angle. Well, with dual inclinometers, the instrument itself makes that subtraction for you so that you don't have to record all these angles and perform all this calculation yourself. But for the validity testing, you will have to perform the calculation. So we take the tightest straight leg raise angle, and from that we subtract the sum of the sacral flexion and sacral extension angles. And that difference should be less than or equal to 15 degrees in order for the assessment to be considered a valid assessment. Now, the AMA guides warn us that this accessory validity test does not apply to every single person in the population. It only applies to examinees who have a sum of the sacral flexion and extension angles below what the AMA guides describe as normal values for these measurements. And for normal, they describe 65 degrees of total sacral motion to be normal for women and 55 degrees to be normal for males. So let's see how this computes into an actual example. Okay, and here the guides caution us to perform our own assessment as to the applicability of the validity test with our particular examinee. And they tell us that the accessory validity test is useful only when the sacral flexion plus extension sum is less than the average for normal individuals, which is 65 degrees for women and 55 degrees for men. At these levels or above, the difference between the sacral motion and the supine straight leg raising will usually exceed 15 degrees because the hamstring and gluteal muscles are contracted in the standing flexed position and are relaxed in the supine position. But for individuals below the threshold of 65 degrees for women and 55 degrees for men, we get a more accurate assessment of the validity of the maneuvers when the tightest supine straight leg raising angle should not be more than 15 degrees greater than the combined sacral flexion and extension angle in the standing position. So let's apply these principles to an actual examinee and see how these measurements are obtained and how the measurements can then be used and plugged into the formula to assess for examinee sincerity of effort on lumbar spine range of motion testing. Okay. So to perform the validity test, you first begin by measuring the straight leg raising angle with your single inclinometer. To do so, you put the inclinometer on the crest of the tibia, zero out your instrument, and raise the leg to the maximum of hamstring tension. About there? Is that about your limit?
Yes. Right.
And measure 3 times, recording your angle each time. And this is an angle measurement of 77 degrees. Make sure to clear the instrument each time. Take it back to maximum hamstring tension until you feel movement of the pelvis. That tells you you're at maximum hamstring length, and that's about it right there.
Yes.
Which is about 80 degrees. Third time. I'll do it.
Sorry.
And back, back, back until there's movement of the pelvis, which is 82 degrees. And record all 3 measurements. Step 2 of the validity maneuver is to compare the finding of straight leg raise testing with the sum of sacral flexion and sacral extension measurements, which we will now demonstrate. Okay, now to measure the sacral flexion and sacral extension angles, you're going to place your inclinometer over the spinous process of the S1 vertebra. Now the S1 vertebra can be found at the center point between the 2 posterior superior iliac spines, which in this model are right here. So some models may be a little bit sensitive about you marking their spinous process, so you can just find that landmark by finding the center point between the 2 PSISs. And I'll mark it right here with a pen. Take your single digital inclinometer, zero the instrument, place it over the S1 spinous process. Again, zero the instrument. Okay, and I'll have you bend forward, reach for your toes, go as far as you can. And record your measurement, which in this case is 74 degrees. And up you go, zero the instrument, repeat 2 times. Repeat 2 times for a total of 3 measurements. And up you go, that's 76. So we got a 74, a 76, and last one. And 74. Okay? And those are all within 10% of each other, so that indicates a valid effort on sacral flexion testing. And now sacral extension, go ahead and lean back as far as you can. Oops. As far as you can. Fine, is that it? Mm-hmm. Okay, and forward. And that's a measurement of 14 degrees. And repeat 2 times. Fine, a little better. Fine, that's a measurement of 19 degrees. And third time. All the way back. Whoa, okay.
Right there.
Extra credit, fine. And that's a measurement of 20. So we had 17, 19, and 20. And in our next sequence, I'll show you what to do with your measurements. Okay, so let's review the measurements and let's make our assessment as to this particular examinee's sincerity of effort on lumbar flexion and extension testing. So this examinee had straight leg raise measurements of 77, 77, and 80 degrees. And the sacral flexion angles were 74, 76, 74, with sacral extension angles of 14, 19, and 20. So we're going to take the sum of the sacral flexion and extension measurements. So let's take the largest of the two with 76 for sacral flexion, 20 for sacral extension. 76 plus 20 equals 96 degrees. We're now going to compare 96 degrees to the maximum straight leg raise angle, which is 80 degrees. 96 minus 80 degrees is 16 degrees. 16 degrees. Would you consider 16 degrees to be roughly 15 degrees? In other words, within the error of measurement margin of these measurements, in other words, we have three measurements here. We have straight leg raise, we have sacral flexion, sacral extension. Within the margin of error of those measurements, would you consider 16 degrees to be roughly 15 degrees? I would in this particular examinee, based on this examinee's effort on the testing and her lack of report of symptoms or provocations of pain with the testing. I would consider her 16 degrees to be roughly 15 degrees, which would therefore make it a valid effort compared to, or as described by the AMA guides, because the AMA guides require that the difference between the straight leg raise and the sum of the sacral flexion and extension be less than or equal to 15 degrees, and in my opinion, based on this examinee, I consider 16 degrees to be roughly 15 degrees and indicative of a valid effort. However, according to the AMA guides would consider this accessory validity test itself invalid because the examinee's sum of the sacral flexion and extension is 96 degrees, which exceeds what the AMA guides describe as normal for females, which is 65 degrees. So let's take these pieces of data and make our overall assessment as to the examinee's validity. So even though the AMA guides invalidate the accessory validity test due to this examinee's hyperflexibility on sacral flexion and extension, even though according to the AMA guides the validity test would be invalid, I consider the examinee's overall effort on the examination testing to be valid because the difference between the straight leg raise test and the sum of the sacral flexion and extension angles is roughly 15 degrees. So according to that criteria, the validity test would be basically valid. And taking that into consideration, as well as the examinee's effort on the testing, in other words, she bent over and she touched her toes 3 times. She achieved maximum sacral extension 3 times. She did not report lower back pain or restriction or limitation on any of the movements. She fully participated in straight leg raise testing. And so even though the validity test itself is invalidated according to the AMA guides, other measures, including partial validity of the accessory test, other measures contribute to my overall conclusion that this was indeed a sincere examinee, and that therefore whatever measurements we obtain on the lumbar flexion and extension testing using our dual inclinometers, I would consider those to be valid range of motion findings and valid for the purposes of providing for permanent impairment should there be some finding for abnormal or loss of range of motion. Okay, so thus the necessity of employing digital inclinometers, or at least having dual inclinometers, or at least having even inclinometers at all. And let me share with you the final reason as to why inclinometers are absolutely necessary in your lumbar range of motion testing. Okay, doctors, so let's conclude today's discussion. And in order to do so, I want you to imagine a scenario where you have an examinee and you've completed all of your range of motion measurements and you've done the validity test, and you're now ready to compare your examinee's range of motion findings against the AMA Guide's descriptions of normals in order to determine if your examinee qualifies for permanent impairment according to the range of motion method. So in order to do that, we refer to table 15.8 to find the impairment rating due to loss of lumbar flexion. And I want to show you and review a couple of things about this table to further convince you of the necessity of obtaining the proper examination instruments as required by the AMA guides. And for spinal range of motion testing, we're talking about inclinometers. And I recommend that you get the dual digital inclinometers. They're about $500 to $600. And I'll include a link as to where you can get those for the lowest possible price in the description below of this video. Okay? So here is table 15-8, and notice in providing for permanent impairment due to loss of lumbar spine flexion, we determine the lumbar flexion angle here in this column. So the AMA guides describe 60 degrees true lumbar flexion angle as a flexion angle that qualifies for 0% whole person impairment rating. So that tells you that the AMA guides consider lumbar flexion of 60 degrees or greater to represent normal or non-impairing range of motion. Well, as the true lumbar spine flexion angle decreases, such as 45 degrees, such as 30 degrees, such as 15 degrees, the AMA guides provide for an increasing level of permanent impairment. However, and here's the catch, and here's where inclinometers are required. The loss of lumbar spine flexion angle must be coupled with the sacral hip flexion angle in determining the examinee's final impairment. Because an examinee who has a lowered or lessened sacral flexion angle has a greater impairment of the lumbar spine with the same amount of loss of range of motion of the lumbar spine. So for example, an examinee who has a 45 degree plus sacral flexion angle but only has, say, let's compare apples to apples. Well, here's a better apples to apples comparison. Well, let's go back. When the examinee has a 45 degree sacral flexion angle but only 15 degrees true lumbar flexion angle, that examinee qualifies for 7% whole person impairment. But an examinee who also has 15% true lumbar flexion angle but only 0 to 29 degrees of sacral flexion angle, this is an examinee who has loss of range of motion not only of the lumbar spine but also of the hip. That examinee now qualifies for 8% whole person impairment compared to 7% for an examinee who had more preserved sacral flexion angle. And as other examples here, you'll notice that a 30 degree lumbar flexion angle in the context of 45 plus degrees of sacral flexion qualifies for 4% whole person impairment, whereas the same examinee with 30 degrees of true lumbar flexion angle but only 0 to 29 of sacral flexion angle qualifies for here a whole percentage point higher permanent impairment due to abnormal motion of the lumbar spine. And doctors, these are findings and angles that can only be recorded by very accurate instruments. This is not something that can be obtained by eyeball, and that explains why many qualified medical evaluators do not utilize the range of motion method, is because they do not have the test instruments. So doctors, I hope this encourages you to make the necessary investment in your examinee, in yourself as a qualified medical evaluator, and in the long-term success of the system that we work in. It's my sincere belief that obtaining the necessary test instruments will make you an infinitely better, infinitely more credible, and infinitely more accurate permanent impairment evaluator. So doctors, I hope this helps you, And I want to thank you for taking the time to join me on today's video. I look forward to being with you on future videos as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.